Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Imagine this. You wake up feeling a little off, maybe some new dizziness or, a tremor that wasn't there yesterday. Your mind starts racing. But instead of dealing with waiting rooms or maybe a really long drive to see a specialist, what if a top neurological expert could assess you, talk about treatment right from your own living room? What if that complex brain issue or spinal cord problem could be tackled without you ever leaving home? Today, we're doing a deep dive into teleneurology. And this isn't just like simple video calls with your regular doctor. It's a rapidly evolving frontier for specialized brain and nervous system care. It's really changing how we get access to some critical expertise.
And our mission today is to truly unpack it all. We're mainly drawing from a really comprehensive research paper. It explores this expanding role of teleneurology, looking at, all its applications, the outcomes, the challenges it still faces. We'll trace its kind of surprising history, explore the clear benefits, but also confront the very real limitations, and then look ahead to where this field is, really going. The goal is for you to walk away feeling thoroughly informed, understanding not just what teleneurology is, but why it matters so much for healthcare today.
Okay, so let's start by setting the stage. How do we even define what we're talking about? It sounds like there are a few related terms, maybe?
That's right. Yeah, think of it like concentric circles. The broadest term is telehealth. That's the big umbrella for delivering any healthcare service remotely using technology. So video chats, remote monitoring, even online health education.
Okay, telehealth is the big picture. And then inside that, you've got telemedicine.
Exactly. Telemedicine is a subset. It focuses specifically on delivering clinical services remotely. Often that's real-time video or audio, what we call synchronous, or it could be store and forward, like sending data securely. That's asynchronous.
Got it. And right at the core for us today is teleneurology.
Yes, precisely. Teleneurology applies those telemedicine principles specifically to neurological care, using tech like phones or video conferencing to diagnose, treat, manage conditions of the brain, spinal cord, nerves, the whole nervous system.
And it's probably important to just briefly touch on neurology itself. It covers this incredibly vast range of conditions, right?
Absolutely. I mean, everything from stroke, Parkinson's, Alzheimer's, epilepsy, MS, headache disorders. It's a huge spectrum. And traditionally, neurological practice relies really heavily on two main things: a detailed patient history, hearing their story, and a thorough physical examination. Often you supplement that with imaging, CT scans, MRIs, or neurophysiologic studies like EEG for brain waves or EMG for nerve and muscle function. And here's the critical public health piece, the reason teleneurology is so important. Neurological disorders, they're actually the leading cause of disability worldwide, and the second leading cause of death. Yet, getting access to a neurologist can be really tough, especially in rural areas. Think about it. In the U.S., about 20% of people live rurally, but only around 9% of doctors practice there. That's a massive gap. Teleneurology fundamentally aims to bridge that gap, deliver expertise where it's most needed.
You hear tele and think it must be super modern, but what's really interesting is that remote healthcare isn't new at all.
Not at all. Early examples, things like signal fires for plague outbreaks centuries ago.
Wow.
Yeah. Then fast forward, 20th century, modern telemedicine starts evolving with telecommunications. You had ECGs sent over phone lines back in 1905. Two-way radio for medical consults on ships in the 1920s.
Oh, I never knew that.
But a really key moment for teleneurology specifically was, believe it or not, 1959, University of Nebraska. They used two-way closed-circuit TV, interactive, to transmit neurological exams across campus, a real precursor to today's video visits.
1959, that's incredible. So the internet must have just blown the doors open then.
Oh, absolutely. The internet expanded the possibilities dramatically. Telestroke specifically really took off in the late 90s, early 2000s. That was driven by the time-critical nature of stroke treatment. Time is brain. Every minute matters. And what's striking about telestroke isn't just that it works, but how it's increased access to treatments like thrombolysis, those clot-busting drugs. It's really leveled the playing field, geographically speaking.
So telestroke was the early success story, but other areas faced more hurdles.
It's exactly. Broader teleneurology for things like epilepsy or Parkinson's follow-up faced big barriers. Reimbursement was tricky, state licensing laws were a headache. Then, well, COVID-19 hit, and that was the undeniable catalyst. It forced this massive, rapid shift to virtual care. Regulations were relaxed temporarily, reimbursement expanded, licensing eased up. Suddenly, teleneurology use just exploded across almost all neurological subspecialties, which gave us this unprecedented large-scale chance to really evaluate how well it works.
Okay, so we understand the background, the need, the tech push. But what does this actually mean for patients today? What forms does it take? Well, like you said, it spans different types. There's synchronous, so real-time video or audio calls. Asynchronous, where maybe images or data are sent for review later. Remote patient monitoring, using devices that send data automatically. And even teleeducation, helping patients understand their condition better remotely. And the specific applications cover so much ground now. Telestroke is the most established, like you mentioned, for rapid assessment, looking at scans, making quick decisions on TPA or clot removal. We even have mobile stroke units now, bringing the ER basically to the patient's driveway. For epilepsy or teleepilepsy, it's great for follow-ups, managing meds, reviewing seizure diaries, counseling, even remote EEG reading. It fits well because so much relies on the patient interview, right?
Exactly. The history is key in epilepsy.
Then movement disorders like Parkinson's, used for follow-ups, adjusting meds, even for deep brain stimulation settings. They can use modified assessment scales, deliver PT or voice therapy remotely. And remote monitoring with sensors is a big growing area. For MS and headache, it's really helpful for ongoing management, symptom tracking, education. Saves patients, especially with MS, the difficulty of travel for frequent check-ins. And for headaches, tracking frequency helps tailor treatment. In dementia, you can do remote cognitive assessments, like a modified MoCA test, manage behavioral symptoms, and critically support caregivers, which is huge. For neuromuscular disorders, it's used for follow-ups, monitoring breathing, though we'll get into the exam limitations, which are maybe more significant there. And even in neurocritical care, like in the hospital.
Yes, remote ICU consults, tele-ICU, remote EEG monitoring. Even in some specific, carefully defined circumstances, helping determine brain death remotely.
Wow. And finally, pediatric neurology and TBI.
Yeah, huge potential there. Addressing specialist shortages, consults for childhood epilepsy, teletherapy after brain injury, counseling for families. It's broad.
Okay, that's a massive range of applications. So let's pivot to the advantages. What are the big wins here?
Right. The benefits are really significant for everyone involved. First, and maybe most importantly, improved access to care. This is absolutely vital for rural folks, underserved areas, people with mobility issues from their condition, or just transportation challenges. It really helps reduce those geographical disparities in who gets specialized care.
That makes sense. Convenience must be a big one, too.
Oh, huge. The convenience and time savings. Patients save travel time, costs like gas and parking, time off work, often shorter wait times for appointments too. And providers save travel time between clinics or hospitals, potentially freeing them up to see more patients.
And cost. Is it actually cheaper overall?
Well, there are potential cost savings. Reduced patient travel, avoiding lost wages, maybe fewer hospitalizations if chronic conditions are managed better. Telestroke, in particular, has shown it can be cost-effective long-term, leading to better outcomes, less long-term disability care, but we'll circle back to the cost complexities later.
Okay. What about the actual medical outcomes? Is the care as good?
That's the crucial question. And for several key areas, especially telestroke, the data shows comparable clinical outcomes to in-person care. We see increased rates of getting clot busters, similar safety profiles, similar long-term function, similar mortality. So it's not just convenient, it's effective. And the evidence for follow-up in epilepsy, headache, Parkinson's also points towards similar effectiveness.
And how do people feel about it, patients and doctors?
Generally, very positive. We see high satisfaction from both patients and providers. They cite the convenience, the accessibility, the perceived quality. For many, connecting from home is a huge plus.
Okay. Any other big advantages?
Yeah, one more. Enhanced care delivery. It makes it easier to loop in family members or other caregivers wherever they are. That's huge for complex cases. You sometimes get unique insights seeing the patient's home environment, and remote monitoring allows continuous data collection, enabling more proactive preventative care rather than just reacting to problems.
Okay, so a lot of clear benefits. But, no technology is perfect. We have to talk about the hurdles, the challenges. What are they? Well, technologically, right off the bat, you hit digital barriers. The digital divide is real. Not everyone has good internet or a computer or a smartphone with a camera. Digital literacy, just being comfortable with the tech, can be an issue too. And let's face it, technical glitches happen. Bad connections, software problems. They can derail a visit. Plus, Getting these systems to talk smoothly with electronic medical records, that interoperability, still a challenge. And then there's the money side again, cost and reimbursement.
Exactly. Big setup costs for hospitals and clinics, tech, infrastructure, and historically, reimbursement for telehealth. It was often inconsistent, lower than in-person visits. The pandemic brought temporary improvements, but the long-term picture for payment parity is still uncertain. That creates hesitation.
What about the rules and regulations?
Yeah, licensure and regulatory hurdles. Medical licenses are state by state. That makes it really difficult for a doctor in one state to treat a patient in another. There were temporary waivers during COVID, but we need lasting solutions like interstate compacts or maybe federal changes for truly seamless care.
And privacy, security, liability. Those must be big concerns.
Huge. Privacy, security, and liability. You have to ensure HIPAA compliance, keep sensitive data secure. That's paramount. Then there are questions about malpractice liability for virtual visits. What's the standard of care? The legal framework is still catching up.
You mentioned the digital divide. Does teleneurology risk making inequality worse?
That's a major concern. Equity and access disparities. While the goal is to improve access, it can actually widen the gap if we're not careful. Studies show lower use among older adults, racial and ethnic minorities, non-English speakers, people with lower incomes, those on public insurance. The digital divide is a big driver of that.
And what about just the human connection?
Right, the patient-provider relationship. Some people, patients and doctors alike, feel virtual visits are less personal. It can be harder to build rapport, trust. There are concerns about, dehumanizing care when you lose that physical presence. And finally, just plain old resistance to change. Some providers, some patients are just hesitant about new tech and workflows.
Okay, those are some significant challenges. It brings up that point you touched on earlier, the physical exam. How on earth do neurologists do that remotely? It seems so hands-on.
It's a great question, and definitely one of the most debated aspects. The good news is, many parts of the neuro exam are actually quite feasible remotely, sometimes even equivalent. History taking obviously works well. Mental status checks, alertness, orientation, language, memory, even cognitive screening tests like a modified MoCA that translates pretty well to video. A lot of cranial nerve tests, visual fields, eye movements, facial symmetry, basic hearing checks, watching palate and tongue movement. You can see a lot. For the motor system, observing for muzzle wasting or twitches, assessing for error slowness with functional tasks like finger taps, hand grasps, checking for drift, watching someone arise from a chair, that's all doable. Coordination tests like finger to nose, heel to shin, and gait, watching someone walk if you have space and a decent camera view.
Okay, so quite a bit can be done. But what about the parts that really require touch?
Right, that's where the limitations are clear. Assessing muscle tone like rigidity in Parkinson's or spasticity after stroke, you really need to feel the limb. That requires palpation, deep tendon reflexes, the knee jerk type thing. You need someone trained there with a reflex hammer. Can't do that remotely without help. A detailed sensory exam testing, vibration sense, position sense, light touch, usually needs an assistant applying the stimuli. Postural stability tests, like the pull test for balance, are generally avoided remotely due to safety risks. You don't want someone falling at home. And fundoscopy, looking at the back of the eye, that needs special equipment right there.
So given those gaps, how reliable are the remote assessments overall? Are doctors confident?
It varies. For telestroke, the NIHSS score, that standard severity measure, it shows really high reliability compared to doing it in person, very consistent. Modified motor scales for Parkinson's, like the UPDRS, also show good reliability and validity, though very subtle slowness or tremor can sometimes be tricky to pick up reliably over video due to tech issues, like lag. But honestly, beyond stroke, the evidence supporting the routine use of a complete remote neurological exam as a full replacement for an in-person one, well, it's still considered relatively weak.
So how do clinicians work around these limitations?
They get creative. They often involve caregivers or family members on the patient's end. Can you hold the camera here? Can you help them with this movement? They use functional assessments. Show me how you walk. Show me how you use your hands instead of just testing raw strength. Clear instructions, demonstrating maneuvers themselves on camera, using validated modified scales designed for virtual use. Incorporating data from wearables or sensors is another growing approach. Or sometimes having a trained telepresenter, maybe a nurse, with the patient in a local clinic. But fundamentally, it's about acknowledging the limits, setting expectations with the patient. And that's why many see hybrid models mixing virtual and in-person visits as the likely future for many conditions.
That makes sense. It's about finding the right tool for the job, sometimes combining tools. So beyond the tech and the exam itself, what's the day-to-day experience like? for patients and providers? Well, for the patient experience, overall satisfaction seems pretty high. People really value the convenience, flexibility, saving travel time and money, feeling safe, especially initially during the pandemic. But challenges pop up, those tech glitches we mentioned. Some worry if the exam is thorough enough. Communication can feel different, maybe less personal, missing nonverbal cues. Privacy at home can be a concern for some. Most find it acceptable, especially for follow-ups. But yeah, preferences vary, and comfort levels aren't equal across all groups.
And for providers, it's a similar story. Generally satisfied, appreciating the flexibility, the reach. Most feel they can get enough information to make good decisions, even for new patients sometimes. They gain confidence in performing many parts of the remote exam, although maybe history taking still feels like the most solid component remotely. But the challenges mirror patient concerns. Worry about the exam limitations, did I miss something? Tech frustrations, difficulty building that same rapport sometimes, more admin work potentially. And those liability and reimbursement anxieties linger. It's definitely a trade-off.
Sounds like a constant balancing act for clinicians. Okay, let's circle back to the money question. Is teleneurology truly cost-effective? You said it was mixed earlier.
Yeah, it's surprisingly complex, and honestly, the economic picture is often inconclusive. A lot of the studies aren't, wow, super robust. Potential savings, sure. Reduced travel for patients, less lost work time, maybe fewer hospital visits if chronic care improves. Telestroke, again, often comes out looking cost-effective long-term in analyses. But then you have the initial costs, tech, setup, training, ongoing platform fees. So while the patient saves on gas, the health system might be paying new software costs. So the bottom line, there isn't definitive proof across the board that it's always cheaper than traditional care. Specific uses show promise, absolutely, but we really need more rigorous, standardized economic studies looking at the bigger picture, longer-term, societal costs and benefits included.
Right, it's not just a simple swap cost-wise. And that brings us back to that crucial point about equity. You said it aims to improve access, but risks widening disparities. How exactly does that play out?
It's a real paradox. The digital divide is the core issue. Unequal access to the basics, reliable internet, computers, smartphones hits older adults, low-income groups, rural residents, and racial minorities hardest. Lower digital literacy often goes hand in hand with that. And the data backs it up. Studies consistently show lower uptake of teleneurology, especially video visits, among these very groups. Older folks, Black patients, Hispanic patients, non-English speakers, people with lower incomes, those on Medicaid or Medicare, they use it less. And that gap didn't just vanish after the pandemic peak, it's persistent.
That's a serious challenge to the promise of broader access. But can it still help reduce other disparities?
Yes, absolutely. That's the other side of the coin. Teleneurology can mitigate disparities by tackling barriers like transportation costs and time off work, which often hit lower-income individuals or those with disabilities harder. So achieving equitable implementation means being really proactive. Strategies like ensuring tech access, maybe loaner devices or community access points, providing digital literacy training, offering culturally and linguistically appropriate services like professional interpreters readily available, designing platforms that are genuinely user-friendly for everyone. And importantly, understanding patient preferences. Maybe phone calls work better for some than video. It has to be patient-centered to bridge that divide.
So looking ahead, what's next? It sounds like professional groups are really trying to guide this evolution.
They are, definitely. And it's not just about clinical standards, it's tackling those systemic issues like payment and licensing. The American Academy of Neurology, the AAN, for example, they strongly support access regardless of where a patient lives. They're pushing for payment parity, simpler cross-state licensing, more research. They also emphasize things like clear roles during a visit, educating patients about limitations, cybersecurity, preventing fraud, the practical stuff.
And training. Are new neurologists learning how to do this effectively?
That's been a big gap, but it's being addressed. An AAN work group developed a standardized teleneurology curriculum outline. It's even been endorsed by the American Telemedicine Association. It covers the tech, legal, and ethical stuff, website manner, like bedside manner, but for virtual visits, consent, privacy, and those specific remote clinical skills for neurology. This is absolutely vital to make sure future neurologists are competent and comfortable with this mode of care. And there are general best practice recommendations emerging too. Things like ensuring good enough bandwidth, using secure patient ID methods, getting verbal consent, involving caregivers appropriately but respecting privacy, prepping the patient, making sure everyone knows how the platform works, basically setting the stage for a successful virtual visit.
This whole deep dive really underscores that teleneurology is this incredibly powerful complement to traditional care, doesn't it? It's not necessarily about replacement.
Precisely. It's about adding tools to the toolbox, optimizing care delivery. And looking ahead, future research and policy need to focus on several key areas. We need more high-quality clinical effectiveness research, big randomized trials confirming safety and effectiveness for more conditions beyond stroke, especially for initial diagnosis or complex cases, comparing different methods like video versus phone or hybrid models. We also need more work on neurological examination validation, refining those remote exam protocols and tools, validating modified scales, exploring how useful peripheral devices or sensors can be to fill the gaps. Equity and access have to remain front and center. Research focused specifically on mitigating disparities, addressing the digital divide, boosting literacy, ensuring language access, culturally competent care. We need better cost-effectiveness analysis, like we discussed, rigorous studies with long-term views considering societal impacts. On the policy and regulation side, continued work is needed. Clear, consistent rules for cross-state practice, reimbursement parity, solid privacy and liability standards to build confidence and sustainability. And finally, embedding training and education into medical school and residency programs is key, making sure all future neurologists are proficient from day one.
So what an incredible journey through this world of teleneurology. We've seen how technology is genuinely transforming access to specialized care, really bringing the clinic much closer to home for many people.
It really is. And it's so clear that while it offers these huge benefits, it's also a field that's still actively grappling with these complex issues, equity, technology limitations, even the nature of that human connection in medicine. Finding the right balance is key.
So here's a thought for you, our listener, to mull over. As teleneurology keeps evolving, how might your own idea of what a doctor's visit looks like change in the years to come? And what innovations in this space are you maybe most excited about, or perhaps most cautious to see unfold?
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.